Bone reduction. So pretty straightforward. You're going to either guide your reduction or eyeball it like Dr. Ross likes to do it with the selective tooth-borne guides. The main gist of it is, of course, a burr choice, and I'm not going to tell you which burrs to use, but we usually like to use a surgical 702. Just go from the buckler approach, lay it down on the guide, go straight across. You're going to be left with some sharp edges, but afterwards, take a surgical carbide football on a straight, kind of round everything out. If you like to use a piezo, go for it. It's I think this aspect here is pretty straightforward. Retraction sutures help a lot, especially on the maxilla. So you notice a lot of our pictures that we included in this course, we have that little loop of a silk suture. It brings all the thick palatable tissue together so that you have a nice clear field to work in. And an obtrugate in the front, and everything's straightforward after that. A lot of the times, we like to hate on pins and everything, but they can actually help you with what we call guided retraction. So the pins themselves, they have a dimension that's a horizontal dimension. So not only does it keep your guide in place, it keeps the lip out of the way. And also, if you know for a fact your patient you're working on has an active tongue, you can even add a portion to your guide that has a plastic kind of tongue retractor into it. If you don't use it, you can always just chip it off. So creativity aspect of making guides. And Dr. Brady, you mentioned irrigation. That's a big part about guided surgery. As you notice, these guides are intimate, so the water that comes out from your drill is not going to reach the implant. So like I said, take it slow because you can overheat the bone and cause necrosis from that point. I've had some ideas actually that, like in here, I made a pin tube into where the implant's going to go for extra oral irrigation while you're working. So that helps a lot. It's a little bit more planning, but either have a clear access with a lot of windows where you're working so your assistant can have some saline and spray it on there. Because honestly, I don't think the saline irrigation connected to our handpiece is enough for guided surgery. So I always like to use a little bit extra. Unlike the first video, the osteotomy was already there. We're just trying to get the drill out of the patient's mouth. Grafting / PRF. So I'm not teaching you guys anything on grafting or PRF, but it's very nice to use in a guided surgery because we're removing teeth. We have remnant sockets left over that we want to close up. And our goal for the final restoration is to have implants that have a good AP spread and to have a nice flat base of bone and gum over the top of it. Because if we have defects, if we have to make our hybrid fill in a void of bone that we could have prevented by just putting some sticky bone in there with a tacked membrane, then it's just going to make it restoratively harder for us later. So at least our goal when we do the surgeries is flat surface, good AP spread, and nice healthy keratinized gums. And I'm a big fan of sticky bone. I don't know if anybody here has used it, but it's a mixture of liquid PRF with particulate bone graft. You leave, the video didn't play, but it's basically like a slab of bone graft that it's not gonna shotgun everywhere after you put it in. So for example, those canine areas, there we go. Those canine areas where, those thin wimpy plates are, and they fracture out, you can pack this, we call it steak bone. It's gonna stay in exactly the area that you pack it. Of course, still please use a collagen membrane of some sort to stabilize it afterwards, but it's way easier working with this stuff. Inserting prosthetic after pickup. This might seem like, hey, I am in my most anticipated, exciting part of the surgery. I can finally put this really pretty hybrid that I just made in the lab back in the patient's mouth. I just grafted everything. There's PRF slugs all over the place. I grafted the sockets. I've closed everything up. You have this temporary hybrid that you guys are all going to make soon. You are standing in front of the patient. You try to put it in. You're like, where are my multi-units? So that's happened quite a bit before. One way to avoid that is to use basically healing abutments that go into the multi-units. Des has them.
You mean you buried them in your bone graft or something?
Yeah, because the goal right now is you've grafted, you got to close it up. So you don't have this exposed, jawbone with implants sticking out with your multi-units exposed. You're closing it up. You have bone graft under there. You have PRF. You have collagen membranes, amnion, chorion, whatever you want to use. It's all closed up. It's all tight. Those multi-units are tiny. So they're going to be buried under there. And not only that, but the amount of tissue that's overhead, like, packing those, what is it called? The sausage grafts or whatever. I forgot the name for it. Finding it and compressing the tissue enough to get your temporary seated is sometimes a very difficult time. The first time I did it, it took me an hour to put the prosthetic that I made back into the patient's mouth because the tissue that I closed up over the arch got in the way of seating it. So these healing abutments are a very nice thing to use because while you're suturing and while you're grafting, it keeps the tissue and bone and all of those materials out of the way of the areas you're working on. You can find them on the DES website, Blue Sky website. You can even print your own if you want. It's basically a exaggerated shape healing abutment that you keep on there as you're working. And if you're delaying the surgery, they can go home with it. They can come back within a few days. And if you want to get really, really fancy, you can create a pre-printed, basically long-term temporary. So some people call them Rosen temps. We are playing around with that idea right now. So you can even send a scan to your lab. They can create a very nice thin temporary that you can print out of one of the new resins, either Bago or an Onyx resin, and deliver it in a few days and just take those healing abutments off and you'll have a nice access to your multi-units. But
something I don't understand, why not just screw in temporary cylinders right at that point? Do all your grafting and PRF and sutures and then do your prosthetic pickup. Because it sounds like you tried to do the prosthetic pickup, but you had buried all the multi-units and all that stuff.
It's possible, but it's still the same issue. You're going to run into the factor of the tissue getting in the way of the prosthetic to guide the prosthetic pickup. And a lot of the times when you're guiding a prosthetic pickup, it's a very good idea, and you can probably do it.
Doing it all bone
pin guided. It's going to be very hard doing it that way.
Okay.
But if you're not doing it pin guided, that could be a nice way to avoid using this, this method of using the temporary healing abutments and everything like that. A lot of people will just lay a rubber dam afterwards if they didn't do any of the pin guides and just squirt cord buildup everywhere, pick it up after the tissue closure. That's a nice tip there.
The other thing too is you got your multi-units on it and you get your conversion. There's still a lot of little post-op work to do on that thing. It's nice to hand that off to somebody else. If there's somebody else in the office that can help with that.
We do it to each other.
Like if you're a second doctor or you train a team member to finish and get the prosthetic ready, then you can be finishing up grafting. It's just kind of a good double team. Sometimes it's just a cleanup, it just needs a backfill of a little flowable and a polish or whatever it might need. It's nice to hand that off to somebody if possible.
Just like the vital extraction therapy that we mentioned, this method here, we haven't experienced a lot of surgeries with it, but I know people are doing it. If your flap is nice and conservative, if you have keratinized tissue on both sides, you can technically leave PRF membranes over the bone, have the flap have a passive closure around your temporary prosthetic, and tissue will invaginate in under your temporary prosthetic with minimal, at best, suturing, if any at all. Because your prosthetic has such an intimate fit with the bone, is it going to be holding all your membranes in place. Now, take it as is, try it if you want to. We like to use the suturing approach whenever we can.